So hello everybody, good afternoon. So welcome to this webinar on primary care in care homes. So I'm a general practitioner here in Worcestershire, where I work at Dudley House Surgery. Our surgery, which is about 8,500 patients, we link to 6 nursing and care homes in our locality. So this is something which we do all the time. And the aim of this webinar is really to look at good practice regarding general practice and how we may work together with and support care homes. So I'm joined by 2 senior colleagues, and I'll let them introduce themselves. But before I do so, I'd just like to pay credit to Dr Gail Allsopp, who's done a lot of work on this webinar. Unfortunately, Gail can't be with us today, but she did ask if I would cover her slides. I think the final thing before I ask Alison and Anita to introduce themselves is that we'll be looking at clinical aspects. I'm conscious that there are a number of contractual questions regarding care homes and how general practice may do that. We'll be concentrating on clinical aspects and regarding any elements contractual and things like this, there would be outside the remit. So could I just ask Alison to introduce herself first, and then Anita, and then we'll move on. So thank you very much.
Thanks, Jonathan. I'm Alison Tavaré. I'm a GP in Bristol, and I have also worked with the West of England Academic Health Science Network for about 5 years. And my main interest initially was deterioration, in particular NEWS, National Early Warning Score. And we've been using that across the system. But in the last year, we've increased our reach to look at identifying sick and unwell patients in the care homes. So the work I'm going to describe is building what we've done for the last year. Thank you.
Thank you. Anita, if you'd like to introduce yourself.
Hi, I'm Anita Astle. I'm a registered nurse. I've been working in our family's care home for the past 30 years. And before that, I specialised in burns and plastic surgery nursing and working in intensive care.
Thank you both very much. So if we could have the next slide, please. So as I said, this is going to be an overview of current good practice, and it's really important, as you see here, that we've got both GPs such as Alison and myself working alongside Anita. We'll be using person-centered care, which is really very important in terms of this context. We'll also be discussing elements of remote consultations, and we'll be touching on things around virtual wards, which is one of the things that's being discussed. And then finally, at the end, we'll be looking at resources that might be available. So that's really what we do. What we'll be planning on doing is the presentation will be about half an hour, and then there'll be around about half an hour for questions, with the plan that we will finish at 4 o'clock this afternoon. So thank you very much. So if we could have the next slide, please. So what you'll have seen in the newspapers is the concerns that have been around care homes, but certainly from a general practice perspective, we consider these as our patients. And I think that's what's really important. We've also been aware in the newspapers that there's been blame from one side to another. But actually what's really important is what Martin Marshall, as many will know, is chair of the RCGP, have said, is GPs have not abandoned their patients in care homes, and to suggest otherwise is completely wrong. Certainly our surgery in Bromsgrove, we have very good relationships. We've set up a lot of the things which we'll be talking about, and many of them have been embedded for many times, for a long time. So, these are important parts of our patients. And certainly they've not been abandoned in any way. And I think anybody who thinks that doesn't understand the reality. So next slide, please. So let's just sort of talk a little bit about the definition. There are lots of names used: care homes, registered homes, nursing homes, residential homes. Probably the main difference is between a nursing home, where you'd have registered nurses and they may have a greater capacity for certainly some of the nursing and medical interventions, as compared to a residential home. And then also I need to be mindful that there are other types of homes around, particularly for those maybe with learning disability and often for younger patients. What's clear about all of them, though, is that they're registered with the Care Quality Commission if they're in England, and equivalent for the Care Inspectorate if they were in Scotland or Wales. I think the other thing to note is that's their home. You know, they may be there and it may be a larger building than perhaps somebody's house, but it is their home. And I think that's a really, really important point in terms of actually the way that we should be considering them. And it should be the same in terms of, as I was doing yesterday, a home visit on a patient, not in a care home. And so this is their home. And that's a really important message. And as we've said before, GPs are committed to delivering the best possible care to our most vulnerable patients, many of whom live in care homes. And again, that's a really important message. So next slide, please. So what I'm going to be doing, and my colleague and friend, Dr Gail Allsopp, did a lot of this work, so the credit to her, is that we'll be using some of the top tips from what's called the GP network we have of clinical advisors. Because what we did is ask a lot of them, what makes a good service, what does a good service look like? And so we'll be using that from across the UK as some of the approaches. So thank you very much to Gail for doing this. These aren't things that you have to do, but they're certainly things which people have found to be helpful in terms of how we as general practice support and work alongside colleagues in care homes and therefore care for our patients. So next slide, please. So the themes of good practice, communication is clearly really important. One of the things that we've certainly found is that having that good understanding, the communication, a clear understanding of communication both ways is really important. But that can be verbal, but also some of the things about resource sharing, which I think are really important. Some of the things we found is that whilst general practice often has local medical committees and CCGs and things like this who can actually provide a more sort of global view on things. Often you will find that care homes are either individual or sometimes in small groups. There are larger groups as well, but sometimes actually having that clear communication, particularly with the smaller ones who may not have the resource, would be quite helpful. The other thing that we found is helpful is that whilst GPs would not be responsible for some of the resource sharing, sometimes being able to guide and support is helpful. Particularly if you're there. And again, I would be very clear, we're not the occupational health doctors for the staff, but clearly sometimes they may ask about things. And I think that that's something we may need to manage. The other thing is the right member of staff may not always be the GP. Increasingly, we're using and working alongside other excellent clinical staff. Certainly our surgery has a senior nurse who specialises in care of the elderly. And actually, she probably would have the same, if not greater amount to offer than I would as a general practitioner. One of the things, though, that is clear, though, is continuity and cover. And actually, one of the things that we would often say is that, yes, it's continuity with the patient so that you know what's going on with the patient, you know what's the background. Perhaps you've had that continuity with the families. But also what's also important is actually having continuity with members of staff. So that's a really important thing. So you actually get to know the members of staff get to know you as the GP or the nurse, and actually you have that trusting relationship. Collaboration is obviously very important. And again, I mentioned a few moments ago about the potential, we're not responsible for teaching, but sometimes we have resources which we might be able to point them to. And also the signposting is here. But what's probably the most important thing is the proactive care. So in our surgery, and this is across Worcestershire where I am, for many years we've been aligned to specific care homes. We provide that service, and actually we provide proactive care. We look when patients become resident, we look at what their needs are. As appropriate, we will do DNA CPR and respect forms, and actually trying to think ahead in terms of what may be the things that that patient may need looking into the future. That's better for them, but also has a potential impact in terms of those who may necessarily need admission to hospital in the future. But all that underpinning this is the mutual trust that there would be between ourselves as the general practice and also the care home. So the mutual trust, communication, collaboration, but in a proactive way are probably are the most important things. Next slide, please. So here are two examples of good practice. The first one's from Grampian in Scotland. So I'll leave you a second. So all care homes have been aligned, and I think that's a really important thing. This is what we've done locally. So we talked about 6 that we have, and all the surgeries around Worcestershire generally aligned to a particular care home, as compared to what it used to be, which was a bit of a free-for-all, where we all visited all of them. So as it says here, building trust and proactive care. This enables care home staff to be our eyes and ears. We trust their judgment, and that's an important thing, isn't it? When someone is unwell, so we know about that. So I think that's really important. And then secondly, in Derbyshire, there's a fantastic relationship between the home and the GP surgery, which is entirely built on trust. The GP surgery listens and takes everything we say on board. It's the same the other way around. The home absolutely trusts the GP. So throughout all of this, isn't it? It's about communication, collaboration, and trust, which I think is the important thing. Next slide, please. So one of the things that's obviously very important in this current time, and certainly we've had some tragic and terrible experiences in our surgery, just as I'm sure you may have had in yours, is the vast number, unfortunately, of patients who have unfortunately passed over recent weeks. We would be very clear of that locally. So this is data up until the 1st of May. And as you can see, is unfortunately the death rate is 159% higher than the start of the COVID-19 outbreak. And when I looked in our local surgery, I thought that the number of patients passing was broadly about double it was last year. And that's a tragedy for patients, for their families, and from everybody. And clearly that has an effect upon us as a surgery, but it also has an effect very, very much on care staff. You know, these, as one of our receptionists said, these were our patients, but actually they were our friends. And that's certainly the case in care homes as well. So that's obviously one of the things that we've been really conscious of over recent weeks. So the collaborative approach is really important, and the mutual trust, especially to get through such a difficult time. Next slide, please. So person-centered care is again really important. There were some anecdotes about general practices actually making block, if you like, decisions about things. That's clearly not right. It's absolutely essential that any decisions, particularly around very sensitive things, regarding things like DNA CPR, are made on an individual basis, and clearly that's the case. And that's what that first point is making. And also to note that there's no change in the Mental Health Act or deprivation of liberty regulations. But also be very clear, and again, we've been very approachable regarding this, is the proactive care, particularly around some of these very difficult, sensitive conversations about what's the best wishes and what would be best for an individual patient. Sometimes, as we all know, the best is actually to keep them at home, to keep them comfortable, to make sure they're well cared for, to make sure that as appropriate, their family are around them, and actually not to admit patients to hospital, and actually understanding what those wishes are, and having those conversations with family and relatives is really important. That's what being a good, proactive, caring GP, and actually working alongside with the care staff is really important. And many times I've done that with the care staff there. Sometimes I've also done that remotely, so a three-way conversation between maybe the care worker still being on the phone, myself, and actually then speaking to the relative. So there are ways that we can do this in a slightly different way. And also some of the comments about the respect form, which is now being rolled out across England, whereby actually we can understand in greater detail what it is that their patients' wishes would be and what their wishes of their relatives would be. And then finally, end-of-life care. What's been very important is obviously, as I've said, is understanding that. There are a series of standards available either through the Daffodil standards, which are very important. They're on the RCGP website. And then the proactive care in terms of actually, as I said, understanding what the patient's wishes would be, but secondly, also thinking that through in terms of whether or not, just in case medication needs to be pre-located. It's always the way that it seems to be 2 o'clock in the morning on a Friday whenever these are used. So that having those medications available and having a prescription so that if they are needed, they're available quickly and without any delay, obviously in the best wishes of the best care of the patient. So next slide, please. So just in terms of COVID-19, we are very clear that sometimes patients can present differently to others. Formerly, the case definition has been cough and temperature, and then more recently anosmia, so the loss of smell. But in many of the patients I would see perhaps in our care homes, maybe very elderly, many of whom have dementia, the cough and temperature, anosmia, I may not be able to get a history. But what we also know is, and this is where the working alongside the care workers is really important, is some of those softer signs are really important. He's normally eating, he's normally drinking, and he's not right. They've suddenly taken to their bed, they've fallen, they're more confused than they would be normally, and actually talking to the carers or the nurses or the care staff is really important. And actually having that high index of suspicion. We'll be talking later about the use of physiology, pulse oximetry, which will come alongside. But some of these soft signs are actually really important. And then in terms of care homes, we'll be having a high index of suspicion at this time, that the staff would consider barrier nursing, the use of personal protective equipment, and potentially isolating that person away from others. But I think we all accept how difficult it can be in terms of working with somebody who might have COVID-19 if they may be confused, and actually trying to keep social distancing where it may be much more the norm in another setting. So, really important that that's there. Next slide, please. So one of the things we did want to discuss was actually stigma. Stigma, is an interesting one, that we need to be there as professionals, both as care workers and as doctors and nurses. And actually to be clear, and if we are worried that somebody might have COVID-19, to say it. Similarly, if we think in reasonable situation that on a death certificate or for a notification of a notifiable disease, which of course the COVID-19 is, that we think that patient may have it, is to be clear. Clearly what we're hoping for, and some places are now started to have it, well, one of our care homes had this recently, where actually they were able to test, and that's quite helpful in terms of understanding what's going on inside a care home. But what is clear is that we need to be clear about this. We don't want to be hiding things because we don't want discrimination, but also we don't want to be hiding things from discouraging healthy behaviours, particularly around other residents. And also if things are not out in the open, then if there is somebody who has COVID-19, and unless it is then made clear, even if it's a potential, then obviously there's the potential that actually it might put other residents, staff and clinicians at risk. So I think the message here is that if you think somebody might have COVID-19, is obviously test, because we can now do that, but actually that needs to be made clear, and those would be the appropriate precautions that people should be taking. Next slide, and I think I hand over to Anita just for a few minutes.
Hi. So on the 29th of March this year, we had our first 2 residents that showed symptoms of COVID-19. And over the past 10 weeks, we've now cared for 39 residents with symptoms, and we've lost 15. So these 2 slides that I'm going to present are based on our experience. Now, normally we have between 16 and 18 deaths in our care home a year. So having 15 deaths in a 2-week period, which is what actually happened, was an immense strain on our staff. And as was explained earlier, there are different types of care homes. There's nursing homes, there's residential homes, there's learning disability homes. there's sheltered housing, and all of these have different staff types working in those. So nursing homes have registered nurses, residential homes will not have anybody clinically trained employed within that organisation. And so when COVID-19 came along, there was a huge sense of fear and also a sense of dread. I can remember when our first person was tested positive, there was that sense of fear. But then, you know, there was the determination that kicked in that we had to do our best. Unfortunately, we'd been supported through a WhatsApp group which had a consultant geriatrician on there. It had various people from across the health community, and there were other care providers, nurses, and home care staff. So we were supporting each other. And what we found is that a lot of the guidance that came out, there was lots of it, but it was often quite unclear, quite woolly, and we had to try and make sense of it. There was also changes in practice. So care home staff were expected to start to verify death, and for those that weren't qualified in any way, that was a huge challenge to them. Some GP practices moved to telephone consultation and Skype calls. And for some care staff, particularly those that are unqualified, they found that of a particular challenge. The other thing is that within care homes, residents have got different needs. You've got from people who are totally independent to people that are extremely dependent with complex needs. And then you've got various levels of mental capacity. So in some homes, people have learning disabilities, some have mental health problems, and most older people living in care homes are living with some degree of a dementia. And as Jonathan's already said, socially distancing these people can be a real challenge. So that was something that care homes had to look at and decide how they were going to meet those needs. One of the other things that care homes were being asked to do was to look at people as individuals, obviously, but to ensure that where appropriate, advanced care plans were in place. And some of the care staff or the staff within those homes found that quite daunting, having those difficult conversations to establish what people's wishes may be and whether or not they wanted proactive treatment. Staff rotation was also a challenge because in my own home, for instance, we have 142 staff, but at the peak of the pandemic in our home, or the outbreak in our home, we had 57 staff that were out of the equation because they were self-isolating. And so trying to reduce transmission, deliver care, and manage day-to-day aspects of a care home were a real challenge. Next slide, please. So one of the things that we found was a huge success to helping us manage and contain this spread was zoning the home. So we zoned into 3 areas. There was the red zone where people who had symptoms or had a confirmed diagnosis of COVID were isolated. We had amber where everybody else was, and then there was the green zone, which was normally the kitchen and areas that weren't going to be interfacing with anybody that may be having any types of symptoms. So zoning and cohorting was separating the areas of the home. Cohorting was segregating staff. And we found that to be extremely beneficial. But again, that is outside of the current guidance that either Public Health England is giving out or the Department of Health and Social Care. But our GPs were extremely supportive in enabling us to do that and to supporting other homes to take that approach, because just isolating people in their own homes wasn't containing the virus. Open, honest and discussion and collaboration was extremely important. And you heard Jonathan say about that. So we were able to share our concerns with our GPs, and the GPs listened and they shared up their concerns with us, and together we were able to move forward. Having common goals, shared goals, was extremely important. Obviously, from the GP's perspective, optimal person-centered care was their focus, and it certainly was from the care home's perspective. And so it was about understanding the individual, understanding their wishes, if appropriate, understanding their end-of-life wishes, and also making sure that those were followed through at the appropriate time. We also looked at preempting what issues we were going to face and how we would problem solve. And we did that collectively, and that meant that a problem shared is a problem halved and all of that. And we were able to really make a difference. And it didn't feel as if being in a care home, working in a care home, we were on our own, and our GPs and their practice staff were really supportive. Frequent communication and check-ins happened. One of our GPs used to, well, still does actually, phone the home 2 or 3 times a week. But not only is he asking how our residents are, but he's asking how we are as staff. How are you coping? Is there anything that you need? And one of the things that they set up was one of their counselling staff is now available to our care home staff should they need them. One of the other things is we both contact each other when we're placing orders, and if we're short of anything, which is, at the moment tends to be PPE, then we're sharing and supporting one another. So the GP practice was having difficulty getting visors, so we gave them visors, and in return they gave us some gowns. So that's been helpful. And Jonathan's already said about mutual understanding. I think we've learned a huge amount from each other over this outbreak, and we've also realised that we can use things like Zoom to share best practice, to train our staff. So we use things like stop and watch, soft signs, and restore to communicate when people are deteriorating, or to identify when people are deteriorating. And we use SBOD to communicate effectively what's happening and what we think we want from the GP. So I hope that the things that we have learned and gained through this outbreak, I hope that they can remain with us and we take them forward, and we don't lose that learning in the future. I believe now I'm handing over to Alison.
Thanks, Anita. And thank you, Anita and Jonathan, for kind of sharing some of the challenges, but also some of the positives of the collaborative working. So what I'd like to do now is talk a bit more about how we're going to be able to continue working together when face-to-face consultations or visits are going to be such a challenge. And so I thought I'd start with patient physiology, which is absolutely key to the management of COVID, and looking at what's going on for a patient and tracking change. So I'm going to talk about Restore 2, but before I go on to that, I just wanted to highlight a bit about NEWS, the National Early Warning Score, because it's been recommended that it should be used in the hospitals for managing patients with COVID-19 by the Royal College of Physicians, but obviously they're seeing patients face to face and they can take a full set of observations. And in the community, that's much more of a challenge because we have fewer face-to-face consultations, and there's not evidence for the use of NEWS 2 in the community. So therefore, it's not currently recommended by the college. I'm not going to go into that in much more detail now, but if you'd like to know more, then we presented a similar webinar on COVID-19 and patient physiology a few weeks ago. And if you follow this link, then you'll be able to see what's happened. And what I'd also like to do is just talk about digital solutions. So if we're looking at patient physiology, how can we communicate this? And briefly mention the COVID virtual ward that's planned and digital support for care homes. Thank you. Next slide, please. So I thought I'd start with the guidance from the British Geriatric Society, which is actually on the RCGP website. And one of the co-authors was Rob Barker, who's a GP in the North East and has undertaken a lot of research into working care homes and patient physiology. And interestingly, they recommended patients should have their temperatures measured frequent intervals. Interestingly, though, that because of course, as Jonathan said earlier, temperatures of older people often don't have a raised temperature. So it's also important that the Geriatric Society recommended that other vital signs should be considered, including pulse oximetry. And they also highlighted the Restore 2 tool as a way of supporting this recognition of deterioration. Thank you. Next slide, please. So Restore 2, for those of you who aren't familiar with it, was developed by West Ham CCG with the support of Wessex AHSN. And the aim is very much to identify when somebody is unwell and support people in communicating what's going on. What it isn't, though, is a clinical decision tool for carers. We're not asking them to make clinical decisions. And for that reason, if you look on the front page in the red box, if somebody's got an emergency such as a severe head injury or severe chest pain or evidence of a stroke, Restore 2 isn't appropriate and the care staff are recommended to call 999. So as I said, there's Restore 2 and Restore 2 Mini, and there are two common themes for it. One is soft signs, and that's really, as Jonathan and Anita have both mentioned, is recognising when somebody's unwell. And sometimes it may be more obvious they're not eating, but we also have to build on that expertise of the carers who've known residents often for many years. And as one nurse said to me, she just knows that she realised somebody was unwell when she didn't complete the crossword after breakfast, because for that lady, that was unusual. So we're wanting to kind of really recognise that expertise, that people who know their residents well, they really can identify something's not right. And then if they have to communicate that ill ease and escalate care, the recommendation is to use the SBARD tool, situation, background, assessment, recommendation and decision. And as part of this, it can include treatment escalation plans, advanced care planning, such as Respect, because that's really quite important. So it's good if our care home staff can know where those tools are kept. And as also mentioned, the Restore 2 full is slightly different, and that includes patient physiology. So the assessment could include a full set of observations. Restore 2 also contains NEWS, but as I've mentioned earlier, there are some reservations on NEWS and COVID. So therefore the escalations within Restore 2 are being adapted to be COVID specific, but the core message remains of take a full set of observations. Thank you. Next slide, please. And as we all know, it's becoming more and more apparent that patient physiology observations are really key to identifying change in COVID-19. And I well remember Mark Juniper, one of my fellow clinical leads at the AHSN, was talking about COVID, and he just said he was seeing patients with the with levels of oxygen saturations that he'd never seen before. And not only were they particularly low, but actually the patient didn't look as sick as he'd expected. And that's a story that's been reiterated and the subject of many different newspaper articles, this silent hypoxia, also known as happy hypoxia. Next slide, please. And so this change in pulse oximetry really has become quite key to the response to COVID. And I'm just going to briefly touch on the COVID virtual ward, which has been developed by the NHS England primary care team. And Jonathan's been part of that, so he can answer more specific questions later. But it's how patients can be managed in the community. Part of it's just asking about symptoms. Are you better? Are you worse? Are you more short of breath? What are your activities of daily living like? Are you more short of breath walking across the room? And one of my GP colleagues said she was triaging a patient who had a poor phone signal, seemed okay, but walked across the room to improve the phone signal, and by that time was really short of breath. And it's those subtle changes which may not be immediately apparent, which we're hoping to pick up with pulse oximetry. And Matt and Ada Kim and the NHS England team have actually ordered 250,000 pulse oximeters, which will become available. Not quite sure how, and Jonathan may be able to have a little bit more information. But you can see that these, by asking questions, seeing what's going on, and with pulse oximetry, we can try and risk stratify patients and decide what's the most appropriate way in which they should be managed, whether kept in the care home and with supportive care or admitted. But again, as we said earlier, it's patient specific. Next slide, please. So how can we actually see this working in practice? And actually, I think this has been working for many years. This was a story shared for me by one of my GP colleagues in Bristol. Local nursing home providing excellent care, looking after a gentleman in his 70s who'd had a stroke, been unwell, possible COVID-19, had been reviewed by a GP the previous day, normal oxygen saturations and respiratory rate. But within 24 hours, he deteriorated quite considerably. Saturations fell to 89 and respiratory rate of 28. And so Lucinda, who was then duty GP and had not actually met this man before, got the phone call to discuss what was the best management for this gentleman. And as she said, it was really helpful for her, for the nurse, and also for the man involved himself, who was able to be involved in this decision making, to have an objective evidence of deterioration, which helped in the way they could decide what to do. Next slide, please. However, as Anita said earlier, and also Jonathan referenced, many of our residents, our patients, aren't looked after in nursing homes, but in fact they're looked after smaller care homes and supportive living. And that can particularly apply to people with a learning disability. And the additional complication there is that people with a learning disability die much younger, as shown by the leader review, which I've referenced below. As you can see, the more profound their disability, the younger they die. And I wonder if that's because of poorer ability to communicate when they're unwell. Not only do they die more younger, but they're more likely to die of infections such as sepsis or pneumonia. So I thought I'd just briefly share another little patient story, and this is in fact my nephew Toby. It's wonderful, as you can see. He's got profound and multiple learning disability. Unfortunately, he's not able to speak, but you can see he's the life and soul of the family. He's there with his cousins and my parents. And because of his disability, he gets recurrent aspiration pneumonia. So I taught my sister-in-law how to measure news, and when he became very unwell, very subdued, which is really quite a change for him, she checked his observations. His news was 6 and he was admitted, and a diagnosis was made, and he was home after treatment within a week. And it's this kind of empowering carers that we would like to be able to share. So not just teaching soft science and SBARD, but if those non-clinically qualified carers are able to take some observations, then if they're concerned, they can then ask for advice and perhaps say, normally, Toby has an oxygen saturations for 97, but now they're 91. And so you can see that objective measure of change helps support what they're noticing. Next slide, please. But obviously, this is quite a change in the way we're asking people to practice. And what we're not suggesting is that you as GPs, as advanced nurse practitioners, as clinical pharmacists working in care homes, that you should provide the training. And the AHSN Network has got many tools. As you can see, there's a link there. So Restore To is often used, but there's also Respect, information on that. And there are other soft sign tools which are also in use. But something else that we really wanted to highlight that the AHSN Network developed along with Health Education England is this set of 14 videos to support carers. They're very simple. A lot of it is just to identify when the patient's unwell, but also talks about SBARD, talking about end-of-life planning. But in addition, how to measure oxygen saturation, how to measure respiratory rate. The videos are only 2 to 3 minutes long, so very easy to view. They can be seen on YouTube as individual videos. But what we can also do is, they can also be viewed on e-learning for health as a package with a few questions after each video. And then if the learner, after they've completed it, can get a certificate to prove that they've undertaken that education. So particularly popular for the carers who work on sociable hours and often find it more difficult to access training. And the videos have only been available for 2 months and we've had nearly 30,000 views. They're proving really popular. Thank you. Next slide, please. However, as I said, the tools are really useful, but to be able to share the tools, we need to have digital support, because that can often be technical challenges. And for some of you who joined early on in this call, we have had significant technical challenges starting today. So we apologise that it actually started a bit later. If you did join late, this will be available for recording and we will take it down very briefly and then reload it onto YouTube so you can see the whole presentation. So we do apologise for that, but it's what happens when you do things that are live. We're not suggesting that GPs should be sorting out digital support, but if I can make you aware of what's out there, the help, then you can signpost. So there's the digital social care website, it's really helpful and has a telephone helpline. There can be help for internet connections. We know that's really important because if you're having a remote consultation with somebody, often these care homes are rather big, old houses, and the broadband may not be, the Wi-Fi may not get into all the consulting rooms. That broadband could be improved. There's help available. And I also wanted to mention NHS Mail, because if care homes have that, can make communication of patient-sensitive data much easier, and also can support prescription ordering, particularly with the onset of the care home pharmacists coming online. I know that the RCGP is includes the devolved nations, so I've been in contact with Wales, and certainly they are developing a website and an app to support care homes, and you will be contacted with that information. And I apologise that I've not been able to find out information of what's happening in Scotland, but if we know more, we will let you know. Thank you. Next slide, please. And so when I was preparing for this, I just asked my colleagues, what top tips did they have? And one of them was like, clarify which device the care home's using. If they've got a phone that's a care home phone, then obviously you can save that note, that telephone number on the residents' notes, because it can be if it's not a personal device. Agree which platform is going to be used. If the staff are worried, ask for observations, because obviously that will help support your discussion, particularly if they're available when you start talking about the patient. As Jonathan said earlier, and was emphasised by Anita, look at continuity. And going forward, because not everything is going to be COVID specific, what about multidisciplinary team meetings? If you've got an NHS net address, then you can use Microsoft Teams. And certainly I can see that we can have discussions, perhaps palliative care discussions with the hospice team, the care home team, the family, the patient, the GP, the district nurse, all signing in perhaps half an hour, making common decisions. Thank you. Next slide, please. And so the resources I've highlighted earlier for the AHSN, but obviously there are a lot of resources on the RCGP COVID-19 hub, as you can see, as Jonathan mentioned earlier, changes to death certification, and also the top tips for GPs caring for care homes, which Gail has done a huge amount of work for, and she's done a huge amount of work on this presentation, and we're really sorry that she was unwell and unable to join us. So do have a look on the website. Thank you. Next slide, please. So it's been a bit of a quick overview, but just the key messages. we've always provided, our aim is always to provide excellent care for patients. It's actually a really satisfying place to collaborate with care homes and know that we can actually do the best for our patients. And we also all want to provide person-centered and individualized care so patients get what they want. And as somebody said to me, if patients aren't admitted into hospital, but they're looked after into the care home, it's not that the care is less, it's just that the balance of care is different, and it's perhaps much more supportive rather than interventional. Relationships are definitely key. But being specific with care home residents, we have to have that awareness. They present differently with COVID-19, much less the temperature, the cough and possible anosmia. It's often more kind of the old-fashioned phrase of off their legs. We should have that high suspicion of high index of suspicion. And alongside this, we need to thinking about physiology. What's normal for that patient? What are the changes? And monitor them over time, because as we all know with COVID, that they often seem to be improving about day 7, 8. That happens to anybody, and then something changes about a week to 10 days. And we're all learning how to do things differently. So let's build on the relationship with care homes. And we're not asking care home GPs to provide the training, but let us signpost to digital support and resources so we can all work together to provide the best for our patients. So thank you very much. Now over to Catherine for the questions.
Thank you very much for all those points that you've raised. There's been some really interesting discussion in the chat, and thank you to everybody who's contributed to that, particularly people who've been answering each other's questions within that discussion. And one of the things that was a key area of discussion earlier was around observations. And I think we did cover that quite a lot towards the end of the presentation. But what I noticed was that people were really noticing this role that people can have, however clinical they are in their settings within care homes, about the knowledge of the person. And then the observations, as someone put it, or a couple of people were putting it, were ways of determining how poorly they were. I just wondered if you'd like to comment on that, from perhaps starting with Anita from the care home perspective, and then bringing in Jonathan or Alison from the GP perspective.
So, I mean, we found that, so as a nurse with 30 years experience in a nursing home, it's usually our care staff that notice that somebody's not well. And it may be, as Jonathan said, they may say they're not themselves, or they're not doing what they normally do, or they're sleeping more, or they're not eating, or they're not drinking, or they haven't been to pick the eggs up from the chickens, or whatever it is that somebody normally does. And then we go along as registered nurses and take somebody's observations and start to notice that, yes, there is a change, and escalate concerns from there to GPs. So using something like Stop and Watch is really good for care staff who don't have clinical expertise, but do know their residents really well, to be able to highlight their concerns.
Great, thank you. Alison?
I'd like to come in on that, thank you. I think, as you say, knowing the residents well is really important. And as I mentioned Rob Barker earlier, and one of the things that he and his team from the North East have done is they looked at over 19,000 news values. And while we said news isn't necessarily diagnostic or in COVID, knowing what's normal for the patient is really helpful. And they found that 66% of care home residents had a news value of 2 or less, which is actually quite surprising. So what's normal for your residents? Can you get the baseline values so that if they become unwell, you can track change?
Great, thank you. Another thing that has come up quite a lot in the discussion has been around the symptoms. When you were describing the original symptoms of COVID, Jonathan, people were starting to comment that the things that were being described as atypical seem to be quite common in their residents or their patients. I wondered if you might want to say a little bit more about the symptoms of COVID and what people are finding.
Yeah, so the interesting thing here is obviously we're learning about this disease all the time. And if we go right the way back to the beginning, it was just on a new persistent cough and a fever. whereas actually many of us were very clear that there were many other symptoms which were in keeping. And actually, you know, if I go back to January, certainly here in Worcestershire, we were seeing lots of people with what I describe as funny flu, which, whilst I can't prove, I wouldn't be surprised were COVID-19 at the time. So I think there's that. And then there are all these other symptoms which we're now discovering, a bit of diarrhea, about 10%. There are some rashes. And then there's the coagulopathies that are now being found. One of the profound ones, though, is this hypoxia. We had one care home where the resident had a pulse oximetry of 66. Even doing all the emergency medicine I've done, I've never, ever seen somebody with a pulse oximetry of 66 before. So that absolutely profound hypoxia. And whilst the patient was unwell, what is happening is because they're not getting the increase in carbon dioxide, they're not short of breath. And actually that's what's happening, we think, with lots of other patients. So normally it's the shortness of breath that would make them call for help, call 999 or ring their GP. Whereas actually what's happening in COVID-19 is that they're getting this profound hypoxia, but they're not getting the hypercapnia, which doesn't give them this shortness of breath. So there are a range of other symptoms, which obviously we're now finding as we learn about this. And I think that as testing now comes in much greater into the fore, I think clinically we would be suggesting, if we are able to as general practitioners, that we would be testing that patient, but given the sensitivities and specificities around testing, which is another issue.
Thank you. There is evidence that more people are referred admission rates are higher in out of hours times and at weekends. I wondered if you might want to comment on what might be contributing to more people being admitted to hospital out of hours and at weekends at the moment. Anita, would you like to come in?
Yeah. So in some care homes, the managers may not be available at weekends or out of hours. So evenings, that's after night. So it is a known fact that in care homes, we will have more admissions to hospital, either at night or at weekends. And that's generally down to staff lacking in confidence, and trying to do the right thing, so escalating in the right way from the staff member's point of view. From others' point of view, it may be more appropriate to follow the person's wishes, their advanced care plan, etc.
Thank you. Jonathan?
And then from a clinical perspective, and I've worked a lot as an out-of-hours GP at times. I think this is very difficult. What we know from the academic literature is actually it's continuity with your practice or your doctor, which is most important. And actually that's right across. So, you've seen somebody, they're unwell, they might have a chest infection. Well, you did whatever you did last time and it worked, so we'll try again. It's sometimes as simple as that. But also, the context, if you're going where you don't know the patient, you may perhaps have a lower threshold to admit. So I think it's continuity that makes the biggest difference. I think there's then something about access, and I've worked alongside many colleagues, again, let's say paramedic colleagues, perhaps their ability to be able to refer into community services is variable. So I think it's a multifactorial reason why admission rates are higher. Some of this is on, as Anita says, about how staffing and ability to manage risk and experience might be within the care home. And then also I think there are issues then around how the health service organises itself, and also the skill mix around that. I don't know if Alison's got any comment.
Yes, thank you. Because I was going to mention that I've seen quite a few papers on implementation of staff being trained to take observations in care homes. And it's been apparent that staff who work unsocial hours and work at night often have much greater difficulty accessing that training. So therefore that would fit with what Anita just said. So one of our aims with the videos was that if they can be delivered as a package on e-learning for health, that those staff who work under sociable hours could be given those tools to identify when somebody's unwell, and therefore that would hopefully improve communication.
That's great, because obviously in terms of continuity and confidence, we're also in a place where there's staff shortages if staff are ill or are constrained by their ability. So availability of resources to increase confidence and tools that can help people make decisions. Some of these things are quite complex as well. In the discussion as well, people were pointing to the fact that if we use clear observations, then we may identify that people have a certain level of sickness, but we also need to weigh that up with their wishes and their family's wishes, and that can get extremely complicated and quite sensitive. I wondered if you'd like to comment on that as well. Who'd like to start?
Well, I could. The case that I shared earlier of the nursing home was a gentleman who had a stroke. So communication was a challenge, but actually with support, he was able to take part of the discussion, and he'd already filled out a respect form saying that had been done some months previously, that he actually wanted to be admitted to hospital and have full interventions. But actually, when he became unwell and there was an objective measure of change, he actually changed his mind. And I think that's it. These, we have to understand that respect forms are respect, and they're active documents that can change, and they're not written in stone, and people can change their minds, but it's actually what the patient wants is key, and shouldn't be imposed on them from general kind of edicts.
So just on the respect form, there were a few questions about that in the chat, Catherine. So the respect form is recommended by the Resuscitation Council. It's being rolled out across England. And in effect, it just gives a much better mechanism to try and get, if you like, the wishes of the patient and those wishes implemented in terms of what they would want. I think many of us would when I looked at the respect form, for those of us who try and provide proactive care and perhaps have these conversations, I will sometimes plant if I've got time. I'd like to have a discussion with you, what your wishes might be. Would you like to, maybe we'll have that conversation next week. What the respect form is actually just trying to, if you like, formulate that. So it's down on a local area to whether or not they're implemented, but it is in many cases now taking over from the red bordered DNA CPR form. And generally, we would recommend that as the approach, which would be better. So I'm conscious of time. Have we got time for one more question, Catherine? And then we'll then probably need to draw to a close.
Yes. I would like to finish with a question from me, which is, this has been an extremely challenging time for particularly for care homes, for you as GPs in the front line, all of you in caring for people, and many of the people responding today. But there are some amazing things that have happened as a result of these really challenging times. I'd like to start with Anita. What are the things that you've noticed and you've witnessed that you would like to see us expanding on and continuing well beyond this current situation, please?
So I would say the commitment of staff to do the right thing, to learn, to embrace best practice has been absolutely phenomenal. They've gone above and beyond, and I think, again, in all the difficulties that we've had, they've proven themselves to be exceptionally caring, very proactive, and to go above and beyond at the time when relatives were very frightened, wanting lots of information, and yearning to see their loved ones, but being too scared to actually do that because of their own ill health problems. So I think there's been an immense work that's been done by our care staff, and it's been great to see them taking the opportunity to work with our GP practices to improve things. In my own home, they've improved medication ordering and advanced care planning as a result of what we've learned through COVID.
Fantastic. Alison, what about the collaboration between primary care and care homes? What would you like to see getting even better beyond this?
I think what's really excited me is the way that we've changed the way we're working. If you told us 2 months ago that we would have had a collaboration between care homes, the RCGP, the AHSN Network, pharmacists, advanced nurse practitioners looking at what we're doing and what can be done better, I wouldn't have believed it. And I feel really positive that all of us have embraced change. It's not that the new normal is going to be different. I don't quite know what it's going to be, but I think there's a lot of positives going forward because I think we can do it better.
Thank you. Final word to you, Jonathan.
Yeah, thank you, Catherine. I think there's some of it is exactly the same. Probably the biggest things are, as Anita says, it's about the collaborative working together. But actually, I think, despite, the huge challenges we've had and some of the complete tragedies that there have been, regarding individuals, so we talked about the number of people, unfortunately, who haven't survived this. And, as we move in towards winter and things like this, I think we're going to have a challenging time. But those relationships and the way that we work are probably the most important things. But then there are some narrow things, particularly around, for example, the way that we've been able to improve the proactive care, particularly around end-of-life care. That's a really important part of, being able to care for people. Just as birth is really important, unfortunately, as we all go towards our end, which we're all going to, getting that right, getting it done in a caring, compassionate, humane way, where people are loved and looked after by their family and cared for by the NHS and the wider care system is really important. So I think there are lots of positives from what I think is a really, really challenging time that we've had so far. So I'm going to wrap up now. So thank you very much for all those who've been listening and watching. I think we've had about 700 as it is about at the moment, but this webinar will be available on YouTube. It'll come down shortly, but then we'll go back up again. I'd particularly like to thank the panelists who've been great in terms of answering the questions. I'd also like to thank all the team behind who've been doing all the techie stuff. Apologies that we had to change the link at the final moment. That was outside of our control, but we had to do that just to make sure that this worked properly. But I wish you well. I wish everybody well at these challenging times, and keep safe and keep well. Thank you very much indeed.